So we're now gonna begin a discussion of talking about which PARP inhibitor to use. So when a clinician has to consider a PARP inhibitor, the first decision is a PARP inhibitor, yes, no, is this patient appropriate for a PARP inhibitor? And then once that decision is made, because the labels are very soon going to be exactly the same, or at least similar enough.
Likely.
Yeah.
So that's unprecedented for us. If you remember in 2005 when we got pegylated liposomal doxorubicin approved, it was easy because it just beat topotecan. So we didn't have to keep talking about topotecan because there's a randomized comparative trial and there's no such thing with the PARP inhibitors. And then when we got gemcitabine approved in 2006, well, that was sensitive disease. So again, we could still talk about pegylated liposomal doxorubicin and carbogem in the same setting, and there was no controversy. And then when you said when we get bevacizumab approved, we got 5 chemotherapy backbones, and there's no competitor to anti-angiogenesis in ovarian cancer. So this is an unprecedented era.
But after 10 years of using, 15 years of using Bev, we still don't know exactly where to use it. So I think we're figuring out.
But these are different questions. So when to use, remember that's the first question. The first question is when to use. I get it, and we will continue to debate that, whether it's front line or second line or in combination. But once you make that decision, which PARP inhibitor? So I'm going to ask Shannon, and we're going to kind of go through this. Ursula talked about the dose reduction and the formulation. So the good news is that niraparib is once a day. I've said publicly that if birth control pills were twice a day, that there'd be a lot of unintended pregnancies, that there is resonance in once a day dosing. But she also said, well, maybe we should dose reduce. So when they dose reduce from 300 to 200. 33% dose reduction. That's generally not what we do. We generally do 20% or less. So in rucaparib, the dose reduction is from 600 to 500, the first one. There's lots of flexibility in the tweaking, but it's not like you can cut the niraparib capsule up. But it's once a day. So as we isolate this one issue, the dose, which is never going to change probably, at least not without a large trial. Does this resonate, this 600 to 500 dose reduction versus the once a day of niraparib?
Well, ultimately we don't know. I mean, I think that.
But for
that
you,
certainly,
in your practice next week, does that mean anything to you?
I mean, it does, but I think that certainly Mansour's presented some sub-analyses of the
Dr. Mirza from Copenhagen.
Of the NOVA data that indicated that there weren't any difference in efficacy with those dose reductions. In fact, the majority of the patients were dose reduced, right? So, but they still saw beautiful impact on progression-free survival.
Hypothesis generating,
so that's
not hypothesis
certainly
testing.
reassuring.
Okay.
Certainly reassuring to me. But I do think you bring up a great point. You know, can you tease out that efficacy at those different dose levels? Does it matter? Is that less than 20% dose reduction made up, or is that something that we really should be kind of sticking to?
You had a comment, Dave?
I think the even larger concern in some regards is the next dose reduction is now a 2/3 dose reduction.
I'm just saying.
So, and you don't have the opportunity to go lower than that. So we went from 300, now we're going to start at 200 with certain criteria, and now the next dose reduction is 100. Now we've taken 2/3 of our delivered drug, and now we're in a different territory. So I do think the once-a-day dosing is very interesting for our patients and clearly more compliant across all diseases, right? From blood pressure to anything else. But the ability to more easily dose reduce, and we know the majority of these patients are going to recover a dose reduction. That's across drugs. The majority of patients, or nearly the majority, will require dose reduction.
So don't feel defeated if you need to dose reduce, because 2/3 need it. If these are fixed doses, bioavailability and patient metabolism and size changes, obviously. So I get it. Go ahead.
And there were also, on that phase 1 trial that was published a number of years ago, I mean, there definitely were, again, this was not a phase 2 trial, but there was indication of response at that 100 milligram dose.
Right.
Yeah.
But also, Brett, I wanted to add, maybe we're holding on to old concepts. This platelet toxicity with niraparib is early, goes away, and as a practicing clinician, I might start at 200 and go 300 the next month if there's not a problem. Now, we don't have any guidance on that, but that may alleviate some of that need for dose reduction.
Once you move beyond the once daily dosing and the more flexibility with olaparib and rucaparib, what are the other factors that you consider once you've decided to use a PARP inhibitor, and assuming the labels are similar, the patient could be treated, say maintenance, which will be very soon. What other factors do you consider other than the flexibility with dosing and the once daily?
You know, I think a patient with pre-existing hypertension, especially if they're having a little bit of trouble to control it, I probably would avoid niraparib. I think that it's going to be additive if they get that product.
Tell us why niraparib causes hypertension. How does that work?
It does have some beta-mimetic activity, and to where you'll see, I think it's about 25%, is that correct, on hypertension? Again, usually controlled.
And that's the only one? The other two, olaparib and rucaparib, do
With
not?
slight hint, but not, slight differences, but not enough to be something significant. So it is really the one that's associated with niraparib.
So I think you said toxicity profile, and you singled out the hypertension. You've discussed the platelets. Dave, what are the other toxicity differences between the 3 PARP inhibitors that are under consideration?
So, it appears that that the LFT elevation is unique to rucaparib, as well as some elevation in the creatinine. We have seen in other PARPs, it was better described in the rucaparib, but I have seen it across the other PARPs. So that's that, and there's a lot of with regards to the creatinine and competing for the receptor. But with regards to the LFTs, it's interesting. You see these LFT elevations, they have no clinical significance.
There you go.
And we watch them, and they go down into within the next month or two. You don't have to do anything. And in practice, you just have to watch them and make sure they don't stay up.
And I would just add to regarding the elevated creatinine, that also typically has no clinical significance.
It's the creatinine
point.
It's regarded to the creatinine. So if you can, you need to calculate a GFR, and if you've got a normal GFR, you can push through. And I agree with you, although it was only really well reported in the rucaparib studies, it is something that we've seen across all of the PARP inhibitors. It's a class effect.
So Shannon, I get asked all the time, is the mechanism of resistance the same for the PARP inhibitors? Or if a patient fails one of the 3 PARP inhibitors, maybe I should just try another one?
There are multiple mechanisms of resistance. We're still, I think, trying to tease those things out. Certainly BRCA2 reversion mutations are kind of the hot one that we've heard about, but there also could be drug transport, things like that. So we don't know ultimately. I think that we will see in clinical practice, and maybe we'll see in studies as well, people trying kind of the PARP after PARP question, especially in these cases of maintenance. When you say you have somebody on a PARP inhibitor maintenance, they're on for a year, they're on for 2 years, they ultimately progress. Can you add a PARP back after you get that patient to a response
So let
again?
me rephrase that. What in a patient that doesn't progress on a PARP inhibitor may be treated differently than a patient that does progress on a PARP inhibitor.
Correct.
Absolutely.
What do you think the chance of switching to another PARP inhibitor is of effectiveness if she progressed on a PARP inhibitor?
At this point, I would say probably pretty low. I think that's where combinations are very
Exactly,
interesting, and
exactly.
both Ursula and I have been involved in multiple trials kind of getting at that question. So you've got a patient that gets single agent PARP, they ultimately progress. Can you add something? Can you switch something out to try to overcome that resistance?
And we have the Oreo study in Europe, which is looking at PARP after PARP. So we hopefully will have at least some of that question answered in the near future.
I was just going to make the comment that I think a number of us are involved in clinical trials where we're starting to try to define the platinum-free interval that we know is not great, but we still use, that 6-month cutoff. What is it for a PARP inhibitor? Is it also 6 months?
Yeah,
is it
good
9
point.
months? Is
Thank
it a
you for
year?
that.
And I think we're just starting to incorporate
Right.
eligibility criteria especially for combinations.
As well as bevacizumab.
Right, no question.
absolutely, sure.
And maybe we need a PARP refractory, PARP resistant,
Yes.
PARP sensitive, just like we have for
Define
platinum.
it like 6 months, I would move.
Now,
what it is.
one caveat being the patients that are on an upfront trial with veliparib, I still would consider
That's a good-
using
yeah.
an FDA labeled drug
Yeah,
in
that's
that
interesting.
population.
That's a good point.
Patient, because I think that's enough different of a PARP inhibitor
Yes.
that I would feel comfortable using an FDA approved PARP inhibitor for that
Absolutely.
patient.
So again, we have 2 questions in the clinic. Is this patient suitable for PARP inhibition? And if yes, which PARP inhibitor? I think we've addressed that.